Good morning, Section 9, or good afternoon or good evening, depending on when you so choose to watch this video. I hope this video catches you all doing well and starting to gear down from a good block 2 week. Enjoyed reading everybody's thoughts and responses. Everybody got their quizzes done, so we've completed block 2 officially, and want to thank everybody for being timely on getting some of that stuff done. Let's move quickly into the wrap up section of this. Some housekeeping information. We're going to be switching to new groups for the remainder of the course, blocks 3 and blocks 4. I will be sending those out with this video attached to our weekend wrap up. I'll also be sending out over the next couple of days comments just to let you guys know kind of what I think you need to do. First, positive, what you've done well, and then some areas that you can focus on if you're looking to improve your scores, if you're looking to get more out of the course. Obviously, it's not always about the grades, it's about the process. We've had a couple of things for some people. We've had weather-related problems, we've had health concerns, we've had some family issues. And so I get it that sometimes that can affect everybody's ability to give it their all, so to speak. But if it's always helpful, I think, to understand where you are in the course, and especially for those who are in residency. The residents I expect to be functioning at a certain level, and hopefully they'll value the feedback so that they can continue down that path to maintain a certain residency level quality. And for those of you in the manual therapy certifications, also just giving you feedback on how you can get more out of this course. Been some really good engagement on the boards. I've really enjoyed some of the back and forth. I love it when I can not only get in my response to people's original posts, but then can exchange and dialogue further. People can engage me in questions. Don't be afraid. Don't be afraid to push back on some of the things I say if you don't feel that to be true. What I would challenge you, however, is to not just push back because you think or you've heard it's a good idea, but because you've seen literature to help support what you say. We sometimes fall back on, well, I heard a colleague say this, or this is what perhaps I learned in one of my clinical rotations. Well, why don't you dig a little bit deeper and go after some information perhaps that backs that up, or maybe unfortunately refutes what you thought to be true, and then challenge the literature, challenge me. I have no problem, and Lord knows that my knowledge base at this point, I've been doing this for 17 years, is not solidified. It's as plastic as our nervous system. As the research evolves, my knowledge base evolves, and I'm continuing to question what I do and what I know, and look for research to help support what I do. Continue to bring in, so then that's a nice segue into continue to bring in outside resources. I really challenge people to bring in more literature. I love the dialogue, but again, let's use the literature to help reason why we do what we do. Some people are getting to be pretty good at that, and I really appreciate that, and I look for that. I'm like, okay, why do they think that? And I like to go back and maybe read an article that they would post. Some people have posted that I haven't seen, and I'm kind of curious, okay, what does that mean, and how strong is that article? It makes, again, for good discussion. So highlights from the week. The proximal hamstring strains. Thinking about differential diagnosis, neurodynamics, lumbar spine, really, really important, right, to be able to tease those things out. I get lots of patients with self-diagnosed, or in the general practice, they get diagnosed with hamstring strains that really have more to do with neurodynamics. And I would argue that neurodynamics and hamstring strains probably go hand in hand. Like, you probably aren't going to have one without another, that there is going to be a component of neural tension. And how do we know that? Just by slump testing them. It's pretty easy to tease out. Lumbar spine, obviously, lots of people have hip and back pain that are intimately connected, and it is a rare occasion where I would just treat it. It's a rare occasion when I would just treat the lumbar spine and not see it in the hips, and if I would, it's usually because of trunk weakness. And if it's not on a rare occasion, I would say, and I don't know how often this would happen, but if I treat out hips, like they have some hip hypomobility, I treat that out, go back and reassess quickly, and their back pain is significantly resolved. That happens way more than just treating the lumbar spine without looking at the hips and just focusing more on exercise. For me, it's the hip and lumbar spine are just two peas in a pod. So are you training the muscles appropriately? Are we addressing this tendinopathy? How are you treating it? And then this kind of goes into the police and RICE. I showed some people the police versus RICE. We used to think that rest, ice, compression, elevation was the way to treat something. I can't tell you how many times you have patients come in, right, who have rested, they've iced, and they've stretched. That's what they love to do. I'm going to stretch it, I'm going to rest it, and it's miraculously going to get better. They don't understand tendinopathy. I go through a fairly succinct but detailed discussion about what tendinopathy is and why load is important. Load progression is important. We learned about the benefits of isometrics, 45 seconds as a pain reducer. I would have, 10 years ago, I was not using isometrics. I had no concept of that. I'm a big fan. I shared with some of you people, you guys, Joe Cook and Purdum's article on tendinopathy from 2009. And if you hadn't seen that, go back to the articles that I posted in Dropbox, pull them down, look at them, because understanding tendinopathy and what it represents is a big deal, right? And so we got to load progressively to tolerance. They need to feel it. And I didn't even police. What does police stand for? Progressive optimal loading, ice, compression, elevation. So completely getting rid of rest, 24 to 48 hours of rest, perhaps, but then load. What is it? What can load look like? Load can look like something as simple as a walk on day 1 and day 2. But then we start to engage it with isometrics. We start to engage it with PREs. We start from a non-weight bearing exercise into a full weight bearing exercise, into a dynamic exercise, and we progressively add. And once people get that, and once they don't have fear of what they're feeling, then real change starts to take place. And we know we start to add connective tissue. We start to take that connective tissue and load it in a way that's no longer disorganized, but in an organized pattern. And the saying is, even with those who have tears in or who have more of a chronic degenerative tendinopathy, treat the donut, not the hole, right? So if we, with a lot of chronic degenerative tendinopathy, we have a hole in the tendon, but we want to treat the outer areas, the connective tissues that's there, hence the treat the donut, not the hole analogy. So anyways, remember that. I've seen too many patients who get referred to me for chronic, quote unquote, piriformis syndrome because all they did was stretch it and maybe do some light, easy things like clams and never loaded it, right, with things like side planks and lunges and maybe some standing TheraBand. I do a lot of standing TheraBand hip abduction for that kind of stuff because the stance leg gets loaded through an isometric while the dynamic leg, or I'll like to do a lot of side planks, partial side planks with leg lifts or full side planks with leg lifts. When that leg down is loaded in isometric hold, that's hard to do. All right, moving on. Hip OA. Okay, I can't stress using joint mobs enough, right? Like they are money for people with hip pain, lateral distractions with internal, external rotation, kind of mobilization with movement. A lot of people talked about prone positioning. Certainly can do that. You can, if they can't get in that position, you can lean off the side of the table and put their knee on a stool. You can, and if you want to be you can want to be super aggressive. You can, put your non-treatment hand on their ankle and pin that foot down and then really mobilize the heck out of that hip. Very, very easy thing to do. I do a lot more lateral distraction with internal rotation. I feel like I do a lot of kind of posterior lateral glides. They're extremely helpful for back pain people as well. Don't forget the Altman criteria, right? Pain in the morning, lacking hip internal rotation resolves quickly. These are key indicators to help you with your differential diagnosis. So you aren't thinking, oh, this is just this is a tendinopathy, or this is more back pain. This sounds very much like hip OA. And for those of you who don't get direct access patients, right? People come to you all the time with back pain, and then if you look at that hip and you're like, gosh, how does this hip feel? Oh, this hip's been bothering me as well. It kind of goes off and on. And if they're over the age of 50, my God, mobilize these people. Regional interdependence, I've kind of already alluded to that with the lumbar spine. But treat the back and hip. There isn't just be able to look at those together. Right. And oftentimes it's the knee, right? People complain of knee pain as a result of hip problems, hip weakness, hip hypomobility. Just keeping in mind, if you're just treating the knee and you're not looking at the hip, you're missing something, okay? All right, enough ranting. Good, but this is also good stuff. Such basic, fundamental stuff that we just all got to be thinking in these terms to get the best outcomes for our patients. So we're going to move on to evidence-based management of selected knee disorders. James is going to have the Charlie for block. He's going to have group Charlie for block 3. New groups. Check your email. So I'm going to switch everybody up, and I'll be sending that out along with that. Contact me with questions. If I've had to reach out to you to ask what's going on, that's an indicator that I need either, we've been late to the game because you have had some issues, and just, let me know. The worst thing that I'm much more sympathetic if I can understand what's happening. Contact me. Let me know, hey, this is going on in my life right now. I got a kid that's sick, and so I've been struggling a little bit. Okay, perfect. I certainly can handle that. Or, work's been crazy, and things are, or I got sick, or I've had a death in the family, or my mom needs help, or, whatever. Just give me a holler so that I know where you're at, as opposed to me wondering, well, I wonder why this person I haven't seen this person all week. Wonder what's going on. Just let me know. So continue to keep up the good work, continue to engage, continue to challenge yourself and me and your classmates as we move through this, because these are just very fundamental kinds of things that we're learning, and we can really move forward to help our patients be better in 3 or 4 visits, right? Like that's a big deal. So take good care all, enjoy your weekend, and look forward to seeing you, well, not next week as we start to get started, as we start to into block 3, but the week after as you respond to your post. Take good care to all. Bye-bye now.